This is Urban Health Today. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Kamal Golla, Senior Medical Director for Value Transformation at Evolent and the lead architect of the new navigation support program. He's here to discuss recommendations to improve specialist engagement with primary care physicians, providing patients access to seamless, high-quality, whole-person care. Thanks for speaking with me today, Dr. Golla.
Thanks, Tamara. And again, thanks for having me on your show.
I appreciate you making time for this. All right, let's jump in. Please talk about your background and your work with Evolent.
Well, again, my name is Kamal Golla, and I currently serve as the Senior Medical Director for Value Transformation at Evolent. Evolent is a leading specialty and primary care enablement company. So, as part of this role, we work to develop a variety of solutions for both health insurance plans or payers, as well as healthcare providers that focus on improving care delivery for patients, streamlining administrative concerns, and also reducing costs for all the stakeholders involved in the healthcare ecosystem. Actually, prior to coming to Evolent, I worked in a couple of different roles, including the Center for Medicare and Medicaid Innovation. And my role there was really helping design the specialty strategy for value-based care, as well as constructing the new Making Care primary model, which we might talk a little bit later about, a model that really thinks about integrating primary care doctors and specialty care within the environment. So clinically, I'm also a practicing urologist with expertise in urologic oncology, and I lead a lot of work in the implementation of value-based care models in specialty care. And again, the goal is to really ensure that patients in oncology, as well as other specialties that I focus on, cardiology and patients with other complex conditions, are receiving cost and quality improvements in their care by really using clinical evidence to guide care decisions. So generally thinking about how do we improve the way healthcare is delivered for patients receiving specialty care as well as primary care.
So that's interesting that you're a urologist by trade. How did a urologist become interested in working with integrating primary care physicians?
Yeah, I love the question. I think I always call myself the urologist who lost his way, or the wayward urologist, because I get that question all the time. So my background has been always thinking about specialty care in some ways, even when I was in my residency training and when I was doing my MPH in medical school and getting my medical degree. I love doing urology research, thinking about how to improve cancer care delivery, but I was always really interested in how do I think about the bigger picture about specialty care, costs of care, and how to really improve the quality of care that patients receive. And I think it really came to head for me when I began practicing, obviously, as a urologist, and I worked in a number of different hospital environments. And especially in certain hospitals, like county hospitals or hospitals with sometimes less resources, I saw the difficulties that patients had, that no matter how much time I spent, trying to open up more OR time or open up spots in my clinic, there was just fundamental issues in the way that they received care that were problematic and actually affected ultimately outcomes. So it could be transportation issues, it could be issues with nutrition or general access to care or cultural barriers. And so I realized that developing a better construct in terms of implementing models that took all of these into consideration was really important. And so really wanted to dedicate my career to finding ways to support the broader population of patients and to build models that really incentivized and were funded to help support patients regardless of that background. And so that's how I got into this space, and then really just naturally grew into it as as I learned about the different ways in order to implement these type of models, and also learned about really the different types of specialties and how there's differences in building models depending on whether it's a cardiology model or a musculoskeletal model or an oncology model. So always an interesting journey, and one that if you asked me 10 years ago if this was where I would be, I would never have guessed that.
So how have you seen the landscape of caring for marginalized patient populations evolve over your career?
Yeah, and I think, I started to touch a little bit on this, but I think it's worth, really talking about this in a little more detail. One thing that's been core to my North Star is really the belief that we can change the way healthcare is delivered. And I talked a little bit about my work with marginalized patient populations during my medical training, as well as my master's of public health, and how kind of further solidified that during my residency training. One of the things that I really noticed was the stark health disparities that exist, especially after COVID. With the COVID-19 pandemic, there were the issues that we're seeing in terms of, again, these vulnerable populations being able to access the right care resources really came to head. And so, one of the most striking examples of that was just seeing my patients who had a new diagnosis of prostate cancer, unable to maybe potentially get the surgery that they need because of housing issues or education issues or income issues. So again, it became clear to me we really needed to create a strategy that incorporated certain public health strategies as well as new clinical interventions um, to manage that and really address those issues. And so I kind of took those clinical experiences, and when I went to work at CMMI, I had a particularly transformative experience. We really looked at designing payment and service delivery models that incentivize providers to focus on health outcomes rather than on the volume of services provided. And I think that shift is really crucial when we think about marginalized populations who suffer from chronic conditions that really require ongoing coordinated care. And in general, what I've seen is that there's a growing recognition of the need for health equity in healthcare policy and practice. There's stronger emphasis now on understanding and addressing the root causes of health disparities. So the evolution has been promising and unfortunately ignited by, a public health emergency like the pandemic, but there's still a lot of work left to be done. I think the key and the work that we do at Evolent, as well as my work prior, is really continuing to build a robust health equity strategy that really drives better care for all our patients, especially the marginalized community. At Evolent, we've been obviously deeply involved in developing and implementing value-based care models in specialty care. And when we design these, we develop specific strategies that take into account the patient's background so that they can receive the highest quality care. An example of that is, there's patients that might have difficulty coming to the hospital because they have limited mobility or their partner can't take time off work. Well, I think those are important considerations to include when you're thinking about treatment considerations like radiation. There's an option sometimes where the radiation treatment could go for 4 to 5 weeks, or it could be shortened to 5 days. And sometimes not only a clinical decision, it's important to consider the patient in front of you and what their needs are as well. And so building in uh, tools and data that incorporates the patient specific needs or health related social needs into how we think about delivering high quality care is really important. And I gave an oncology example, but similar in cardiology. We really want to ensure that we are best enabling access to care that's culturally competent and that takes into consideration the unique needs of the patient.
Out of curiosity, how did you identify the patients not able to get care because of their housing issues? Did you do social determinants of health? How did you isolate those patients? How did you ID them?
Yeah, we have, there's a couple different ways. We have we in our navigation program, for example, we have a social determinants of health screening that we utilize, where we ask these critical questions about housing insecurity, nutritional needs, transportation needs, what's your caregiver support, what's your familiarity with the healthcare system. We know how hard it can be for an individual to navigate the health system. So just as important is to understand what chemo treatment they're going to get or what's the information about their biopsy. We feel that like getting this information up front is equally important because then we can get them connected to the right resources up front. And more importantly, in some ways in the navigation program that we've designed here at Evolent, we realize it's hard for providers and physicians to sometimes spend the time to get all of this additional information about the patient that is really important, and it would be included in this bucket of health-related social needs. So not only do we get the information, we find ways to communicate that information to practices and providers. And so I think that's a really important element of any kind of healthcare model that we build.
Why is there a shortage of primary care physicians? And how does this impact patient care, especially among marginalized patients?
Yeah, this shortage of primary care physicians has unfortunately been a growing issue. And at some points, and I think I've said this elsewhere, sometimes it really does feel dystopian to see
Mm.
how short, how short we will be in terms of being able to provide primary care services to our population here in the US. And much like other aspects of healthcare, these shortages or disparities disproportionately affect marginalized communities because many times they have higher disease burdens or less access to preventative care, and all of these things become exacerbated, right, when we have a shortage of physicians. And so there's, in terms of why there is a shortage of physicians, there's a couple of reasons. One of the, I think, I always start with a little historical context when I talk about, the shortage of physicians. I think there's um, there's always issues in terms of the workload that
Mhm.
physicians, especially primary care physicians, are expected to carry, and that's never changed. In fact, it's only grown over the last 10 or 15 years. Primary care physicians, one of the statistics I always include is that um, primary care physicians, if they were to do all of the things recommended by society guidelines, they would need to work about 26.7 hours a day. With
Oh
only
my
24
goodness.
hours in a day, exactly, 24 hours a
Yeah, I
day,
caught that.
there's not much not much flex in their day to be able to do all of that level of work, and it's just because the complexity of the patients has gone up. We've have new innovations in medicine that have turned diseases that would normally be terminal in say that even the oncology space to now they're treated as chronic conditions, and these
Mm.
patients are then following up with their primary care doctors. And so there is a significantly growing need of patients that primary care doctors have to manage. And unfortunately, that's tough on primary care physicians. It makes it really hard for them to carry a panel of almost 2,500 patients. And what does that lead to? It leads to burnout. And so what we're seeing is a churn in primary care where um, we're seeing folks trying to potentially leave the field early because of the amount of work and onus and burden honestly put on these individual providers. Uh, and then we're also seeing financial changes. One of the things that we've commonly noticed in the market is that primary care physicians are reimbursed, less than specialists. And one of the recent market changes has been the introduction of something called the V28 modifier, which basically changes how patients are risk stratified. And basically that affects reimbursement for physicians and specifically primary care physicians. And so that modifier has significantly impacted revenue for primary care practices. And as a result, many practices are underwater. And again, that makes it difficult to sustain or retain providers who are dealing with these financial difficulties. So there's market dynamics. There are the individual burdens that primary care physicians are facing. One of the other things that we see commonly in medicine is that we're also not necessarily investing in primary care physicians, right? The number of residency spots have generally decreased, but populations have grown. So there have been, I would say a perfect storm of events that have contributed to the PCP shortage.
Wow. Well, you've talked about the increased demand for specialty care reaching unprecedented levels. Is it because of the shortage of PCPs, or is there more of a trend? Is there more to the trend?
Um, yeah, it's a great question, Tamara. And I think starting with some historical context is always helpful here. As we think about healthcare transformation, it's really what it's really focused on the past 10 to 15 years it's been on the creation of what we call accountable care organizations. And what's an accountable care organization? These are entities that are made up of a group of healthcare providers whose goal is to improve the quality of care for their population of patients, but they're also responsible for the cost of care for that population. And really, their goal is to be able to address the full range of a patient's need. And so that includes not only primary care needs, but also specialty needs, for example, cardiology, oncology, musculoskeletal disease. And all of those have to be addressed. So to get back to your question, the trends that we're seeing in specialty care really support the need for this integration. But within the US healthcare system, what we're seeing is that there's an emphasis on specialist diagnostic and treatment approaches to patient care. So, an important statistic here, I think, is we see that almost a little more than 30% of patients are actually referred by their PCPs to specialist providers, and over 50% of all outpatient appointments take place with specialists. And so, because of the way that we're managing healthcare, there's just been a really profound spike in the utilization of specialty care needs. Another, again, we've talked about this before, but the COVID-19 pandemic has played a role here on really this profound impact on healthcare utilization, particularly in specialty care. During the early stages of the pandemic, obviously, we know many elective procedures and routine checkups were postponed or canceled because the healthcare systems were just frankly trying to focus on managing the surge of COVID-19 cases. And this led to a significant backlog of patients needing care. And then as the pandemic progressed, we saw an increase in the severity and complexity of patient diseases or presenting to specialty care physicians. So patients that were delayed were seeking care. Patients actually delayed seeking care, obviously, during the pandemic, and during their time, their conditions worsened. And what happens then is that a specialist has to deal with utilize actual procedures or more intensive and complex treatments to manage a worsened disease. And so we're actually seeing the results of that, where patients are presenting with higher rates of metastatic cancer, for example, in the
Oh,
prostate cancer
wow.
population. Yeah, and what that means is that instead of being able to maybe cure or treat with either surgery or radiation, they need very expensive treatments to actually manage their prostate cancer, and they have to see a medical oncologist, and they still might need radiation or other interventions. And so, again, I think another example of a perfect storm here. And when we talk about marginalized communities, these are the individuals that are disproportionately affected, right?
Right.
These patients have already had higher rates of chronic conditions, already had less access to primary care, which means that they're even more likely to end up needing specialty care because it has become that much more, the disease has worsened that much more. And so, again, I think we're generally seeing this increase across the country.
Now, is accountable care, is that related to value-based care at all?
It is. I think there is a lot of overlap in the concepts of value-based care and accountable care. I think generally the framework is very similar. In value-based care, you're thinking about how to improve quality while decreasing costs, and similar with accountable care organizations, there's entities that are focused on the same framework. And so what you'll see that in the last 10 or 15 years, that accountable care organizations were implementing value-based care strategies in order to manage their population. Again, the lens had largely focused on primary care patients. Now what we're seeing is that shift on value-based care is not just on primary care patients, but on value-based care strategies for specialty patients as well, which is really what we focus on here at Evolent.
Fragmentation of care is a recurring issue in the healthcare system, especially when patients transition between primary care and specialists. So what are the biggest challenges PCPs face in ensuring smooth coordination with specialists?
Another great question. And I think I hold this topic kind of near and dear to my heart, not only as a practicing specialist, but also in the work that we've been doing. So really ensuring smooth coordination between primary care physicians and specialists. It's crucial to patient care, but several challenges. One is this idea of incompatible, really, electronic health records, for lack of a better term. Our doctors don't have a way, primary care specialists and specialists don't have a way to communicate with each other. And this is this idea of a lack of interoperability between the two physicians. So when I say lack of interoperability, what I mean is that there is no common platform where primary care doctors and specialists can communicate about a particular patient. Now, if you think about an academic center where maybe there's one big umbrella and they're all using one particular EMR, there's some level of communication, but a lot of care is actually delivered in the community. And in the community, they might be using different electronic medical record systems. They might be using fax to communicate with each other. Maybe they're just phone calls. And so this makes it really difficult for physicians to be able to communicate complex patient treatment plans. And as a result, you can imagine with a communication loop like that that's fragmented, it can lead to incomplete or delayed sharing of patient information, which ultimately impacts the patient's care. Another one is this idea of role clarity. There can just be confusion about the roles and responsibilities of each physician during a patient's care journey. So, you have a patient with a cardiac disease or heart failure, for instance. When is a specialist expected to manage the condition long term or provide consultation versus what parts is a primary care doctor supposed to manage? And it does vary. There's some primary care practices that are larger and have more support that might be very comfortable managing a specialty condition further along the pathway and maybe less likely to need a specialist up front. And in other cases, the primary care doctor may need to pass the patient over to a specialist earlier in order to be able to manage that patient effectively. But it is a very heterogeneous idea on how that looks across the country. And so role clarity can be very tough. And that's confusing to the patient and also can be frustrating for the physicians. And then one thing that we're solving for at Evolent, but one that's always worth mentioning is this idea of primary care physicians, frankly, even knowing who to refer or identify what a high value specialist is. If you think about how hard it is for us to find a doctor and know if they are quote unquote good or not, we might use Google reviews or Yelp or ask our hairdresser or talk to our neighbor. And in some ways, physicians have the same problem. It's hard for them to know when they're referring a patient for a specialty need, hey, what are the clinical outcomes that this specialist is focused on? Do they have good outcomes? Do they have a lot of readmissions? How well do they perform these surgeries? There are just not a lot of great options or tools out there that are readily available to understand the quality of the specialist you're referring a patient to. And again, that adds some additional abrasion in the process as well. And so those are things that we actively think about solving for at Evolent in terms of being able to provide that guidance to our primary care physician partners.
So what strategies do you think could help alleviate the burden on PCPs and improve care coordination in light of this lack of clarity into whether a particular specialist provides high quality care?
Yeah, there's, again, Evelyn, we recognize the importance of primary care physicians across the care journey. And so what we do is find as many ways as we can to really arm the PCPs with tools to become much more successful in managing a patient holistically. So we have a couple of tools that we've designed and deployed, and they range from what we call high value scorecards. And what those scorecards actually do is help PCPs identify which are the specialists that don't, for example, lean on unnecessary surgeries or interventions, but rather start with optimal medical management. So that's an example. We'll build out a scorecard that really helps the primary care physician identify a specialist based on clinical outcomes as well as what we call operational outcomes. Are they accessible? Um, are they able to manage this patient with the full set of tools available to them, or are they more likely to jump to surgery? So there's so many different variables here, and so we try to package this up as a scorecard. So they have what I would say, a high level view that gives them guidance about, hey, here are the specialists available in your network. And here's here's some of the information about how they manage patients that might be helpful for you when you're referring patients. One of the other tools that we offer is really helping guide them on referrals themselves. For example, one of the tough questions that's hard for a PCP to answer, say in the oncology space, is, hey, should my patient be going to a community doctor, a community oncologist versus an academic oncologist? What cancer types would that be relevant in? And so we actually provide white papers as well as talking points to help kind of really digest the clinical expertise we have, say, in oncology, but the same in cardiology, to say, like, hey, in these certain cancer types that require treatment that are typically surgery, radiation, plus some sort of chemotherapy, certain settings might be better. And so we will actually be able to help lay out a little bit more of a roadmap for the primary care doctors so they can have a more informed conversation with their patient, as well as have a little better insight when they're referring a patient to a particular practice. So those are a couple of the tools that we've created in oncology as well as in cardiology to really help support them.
Now, the high value scorecards, are they patient information driven? How do you come up with them?
Yeah, it's a great question. The scorecards typically do focus on the providers, meaning what their outcomes and you know what clinical outcomes they achieve, and also some of the other aspects, like we said, accessibility. But it's a great question because what about the patient? How are they included? And I think that's where our navigation program comes in. So for our navigation program, we think of it as like a wraparound service for these patients that have been diagnosed with cancer. We're able to collect data that's precise to the patient, and that includes some of the things we already talked about, like health-related social needs, but it also can include what they want out of their life. What are their treatment goals? What are their goals? What's their career choices? Are they working? All of these kind of other aspects of the patient, we're able to kind of synthesize and share that back with both the primary care physician and the specialist so we can help inform their decisions. And so, and then we actually obviously spend a lot of time with the patient themselves, teaching them about, hey, your first visit with your specialist is coming up. Here's how do you want to structure your conversation with the specialist? They're going to obviously talk about what drug regimens might be most helpful, and some of the clinical aspects, but let's make sure we get across what's important to you in terms of your goals of care, in terms of what's meaningful for you. What do you want to achieve in terms of the treatment? What do you want to see long term? Because those are all really important things as well. And so we help support the patient be able to articulate those thoughts with the specialist and the primary care as well.
Dr. Gola, many patients are now waiting more than a month to see a specialist. I am finding personally for routine specialty care, 2 to 3 months wait time for an appointment. And this leaves them vulnerable to disease progression or emergency department visits. Can you recommend any improvements for facilitating timely access to specialty care?
Yeah, absolutely. It is definitely tough getting timely access to specialty care. And like you pointed out, crucial for preventing disease progression and really even avoiding things like unnecessary emergency department visits. And so some of the recommendations I've had, and it does vary obviously based on patient needs, but there's a couple of buckets that I find helpful to think about here. So one is telehealth services. We've listed a few difficult areas that have arisen because of the pandemic. But one of the areas that we've seen a growth in is telehealth services or virtual consultations post-pandemic. And so I think virtual consultations, there's expanded telehealth services that really allow a patient to consult with specialists remotely. There's several services in the ecosystem where you can essentially have your primary care physician chat with a specialist asynchronously so they can ask some of these questions to see if you even need to see a specialist, for example. And when you do, you can then work on a referral. And then sometimes it's enough to start the first patient visit with actually a virtual consultation. And that can hopefully reduce wait times, increase access. This is particularly important in rural or underserved areas where there just may not be a specialist serving that region. And so I think telehealth services is one big bucket that I always encourage folks to think about. And always, I think an important part of how we plan for future capacity in specialty care. Because we don't see this problem going away anytime soon. Another one is, as we think about how we change actual operational processes, thinking about streamlining referral process, right? Is there centralized scheduling? Is there a centralized scheduling system for the specialists to really optimize appointment slots and reduce wait time? So this is, I think, things that a lot of practices are thinking about, health systems are thinking about, because they know there's a capacity issue. So reworking some of the internal processes to really find some additional flex in the schedule to be able to see more patients. Another bucket here is something called referral management system. So using a system to track and prioritize referrals based on urgency. So that way patients with more critical needs can be seen sooner. So it's just not that you have a new diagnosis, but what type of diagnosis you have. A lot of physicians have to make those kind of decisions, on an individual basis, but there is a lot of work that's going in place to do that at a scaled, more system-wide level to accommodate capacity. Obviously, the models that we talked about, integrated care model. So finding opportunities to co-locate specialists within a primary care practice, actually embed, say, a cardiologist or oncologist within a primary care practice or community health center. I think that can facilitate easier and quicker access, especially for those that are more urgent needs. There's multidisciplinary clinics that have been established that have a similar concept where you can see multiple specialists in one visit, especially for those with complex conditions to improve efficiency. And then, patient navigation, I think, is a really important element here. And one that we focus on is really employing navigators, like the team that I run here at Evolent, where we help with things like scheduling. We help with things like collating all your labs and imaging tests and all of the pieces that need to be included before you see your specialist. Because sometimes what happens is you get this appointment with your specialist, but you go there and you find out, oh, I didn't have this particular imaging test for my doctor to make a decision. So having that insight about what a physician needs on their first specialist visit really helps reduce the number of trips back and forth and inefficiencies in the system. And then finally, I think there's really important changes in terms of at the policy level. So, how are we funding healthcare infrastructure in underserved areas to expand specialist services and reduce wait times? How are we advocating for reform, at a national or state level to reduce barriers to access to specialty care? At Evolent, we think about different ways to improve the process in which patients get approval to get a particular intervention or a particular drug that's quicker, more streamlined, and that way that there aren't any delays in care. So I think a number of different ways that we can approach it. I don't think there's unfortunately one solution that's going to fix it.
Forgive me, Dr. Gola, but aren't payers pulling back on paying for telehealth services since the pandemic?
Yeah, they have. They have pulled back. And I think there's obviously reasons, both regulatory reasons, why some have pulled back. What I would say is that There are still innovative companies that have continued to invest as a wraparound, especially in rural and underserved areas, to provide telehealth services. Um, these would be where policy changes are still very important, where yes, there might be some pullback in some cases on telehealth services, but I think there's still a large movement to continue to reimburse in certain specialties. For example, we think about behavioral health. I think there's still pushes being made to continue to support telehealth services because we know how vital that is. So I don't think that the story is fully written on that. I think there's still continued work by both physicians and allied health professionals to really showcase the importance of virtual care. So I know that's something that we continue to advocate for.
Fair enough. What advice would you give to patients navigating a healthcare system in which PCPs and specialists are increasingly scarce?
Yeah, yeah, this is another really great question. And I think navigating a healthcare system can already be a challenge. But this is some of the advice that I give my own parents when I think about the current state of the healthcare ecosystem. So first is really establish a strong relationship with your PCP if you already have one. If you already have a PCP, make sure you build a good rapport with them because they really are your advocates to help coordinate your care and even if specialists are come by, they're the ones that will advocate for you to be able to get into their offices. And so importantly, regular checkups, open communication with them is really key. And I think it leads into my next point, which is primary care. Having that relationship also is important because it helps you be proactive about preventative care, right? Focus on preventive care really to avoid the need for more complex treatments later is extremely important. It's the basics. Are you up to date with your vaccinations? Are you getting your cancer screenings if appropriate? Are you making healthy lifestyle choices? I think preventative care can really obviously help catch these issues early enough when they're easier to manage. And again, I think your primary care doctors are really your champions for that. So focusing on that is really important because I think sometimes the best way to manage the healthcare system is to find ways to reduce the ways that you need to actually be seeing a specialist if you can. It's just the reality and the environment that we live in. We talked a little bit about utilizing telehealth services and I think for follow-up appointments and things like that. I think that telehealth services, if obviously if your insurance will cover it, still is a convenient way to access care and allow you to maybe achieve some of those the same kind of maintenance and being engaged with that proactive preventative care that I mentioned without necessarily having to go to see the physician. And I also say, look out for, community resources, right? A lot of community health centers and clinics offer services based on a sliding scale, based on your income. So these centers can often provide comprehensive care. They sometimes run free screening clinics. In general, they can be a really great resource. Say you don't have a PCP or a specialist, they can be great resources in terms of finding a physician for yourself. And then, one I always have to remind not just my family and friends, but myself is advocate for yourself, right? Don't hesitate to ask questions. You got to seek second opinions if you're unsure about diagnosis or treatment plan. Being informed and proactive about your patient, about being proactive as a patient can really help you navigate the healthcare system more effectively. And so that's a piece of advice that's easy to give, but hard to actually practice. But I think really important to have to really advocate for yourself or your loved ones. And then finally, when we think about alternative care models, we are seeing things, and again, there is a price associated with things, but there are alternative care models like direct primary care models or care options where you're paying a monthly fee, for example, for more personalized access. And again, these can be frankly cost prohibitive depending on the option that's chosen. But
Yeah, I was going to say that's probably not very easy for a low income patient to swallow.
exactly. And so I think, unfortunately, that's, I know people have turned to those as resources, but they're, not great resources in terms of patients that don't have the financial means.
Well, this is a lot of good advice to get patients started. Dr. Kamal Golla, thank you for your time today and for your work in the patient care access space. Really appreciate speaking to you today.
Thank you so much, Tamara. Really enjoyed speaking with you as well, and appreciate you having me on the show.